Now it is a time for the Servier Symposium. Professor Dr. Rami will talk to us. The topic will be around the cornerstone of management of pancreatic cancer. Please, Dr. Rami, the floor is yours.
Good afternoon, everybody. Thank you so much, Mr. Chairman, for this nice introduction. Regarding high unmet medical needs and unique biological characteristics of pancreatic cancers, as we all know, that pancreatic cancer is relatively a rare disease compared to the breast cancer, compared to prostate, compared to lung. And regarding mortality for pancreatic cancer, as we see, it's high, and it's very high compared to other malignancy, despite it's a rare disease. But I think that we are seeing this cancer more frequently in our clinic this time. Patients with pancreatic cancer have a poor prognosis. Why? Because the median overall survival typically reported is less than 12 months. 2 to 6 months median overall survival for pancreatic cancer who are metastatic, and the 5-year overall survival does not exceed 10%, and almost more than 80% of the patient had advanced disease at diagnosis. We all know that 20% of the patient are candidates for Whipple, and among those patients, 80% of those patients relapse within the first year. That's why it has a poor prognosis. Unlike other cancers, there have been almost no improvement in pancreatic cancer survival rate, as we all see here. It's a flat curve, as we see, it's flat, and there is no improvement compared to breast, lung, and prostate cancer in last years. And also we have a high expected increase of pancreatic cancer cases from 2020 to 2040, and pancreatic cancer is anticipated to be the second most common cause of death among malignancy after lung cancer. Regarding clinical trial, we see that cancer pancreas, we had a failure of several trials all over the years. The pivotal trial for pancreatic cancer we know in 1997, where we all know that now we have the gemcitabine, which was superior to 5-FU. Then in 2007, we had some trial with adding erlotinib to gemcitabine, and in 2011, we had the FOLFIRINOX. We had a survival benefit over gemcitabine single agent. Then we had the gem-nab-paclitaxel, which was superior to gem alone, and we had a maintenance olaparib in 2019, and in 2015 here's the introduction of the Naleri 5-FU leucovorin, the Onivide with 5-FU leucovorin, which had a survival benefit compared to 5-FU leucovorin as a second line. Why pancreatic cancer is difficult to treat? It's really difficult to treat because of its microenvironment, because we see that pancreatic cancer has a dense stromal layer, immunosuppressive tumor macrophages, low microvascular density, and leak vasculature. All this challenging in this behavior or the biology of the pancreatic cancer lead to insufficient drug delivery and inadequate tumor exposure. Regarding the management, as we all see here, we had the gemcitabine superior to 5-FU, and then we had the gemcitabine compared to FOLFIRINOX. We had a survival benefit of 11 months compared to 7 months where FOLFIRINOX was introduced in the metastatic setting compared to the gemcitabine, and we had 2 months benefit when adding gemcitabine with nab-paclitaxel compared to gemcitabine alone as the first line. Regarding second line, it's an unmet need because we did not have any treatment protocols that had a survival benefit as a second line, and the majority of the trial were against placebo or were a single arm protocol as a second line. We all know that if the patient received a fluoropyrimidine, so a second line he will take a gemcitabine, and if he had received a gemcitabine, he will receive a second line fluoropyrimidine, but with no head-to-head comparative trial. Here comes the benefit, or the unmet need to which Onivide was introduced. Onivide, which is a pegylated liposomal specifically designed to effectively treat aggressive tumor like pancreatic cancer, which have a difficult microenvironment. Onivide is a unique pegylated liposomal formulation designed to overcome the pharmacological and clinical limitation of non-liposomal molecule like irinotecan, with enhancing tumor efficacy while reducing toxicity. How? Because it has a polyethylene glycol, which has a high stability and hydrophilic polymer coating. This coating helps to protect the liposome being rapidly cleared from the body, as we see. Also, it has a lipid bilayer which protects irinotecan from early conversion to its active molecule to be SN38, as 95% of irinotecan remains liposomal encapsulating during circulation. Then we have also the high drug loading capacity for this molecule. This is the mechanism of delivery of a liposomal coated drug or the liposomal coated irinotecan. As we see here, the liposome circulates longer in the bloodstream with limited circulation in plasma. Then the liposome preferentially enters the tumor environment due to the penetration power of the molecule by binding to the macrophage, which is present as a difficult microenvironment of pancreatic cancer, and after uptake by liposome by tumor-associated macrophage, it is, as we see, converted into the active metabolite SN38, and this has almost 1,000 times increased activity versus irinotecan by the carboxyesterase. That's why we have a higher affinity, more time of exposure, good penetration, and more concentration, and this concentration is inside the tumor cell due to the liposomal codes. That's why the prolonged exposure of SN38 on the tumor leads to significant tumor growth inhibition. So the Onivide, which is versus the conventional irinotecan, the Onivide lasts more than 3 times as long in the bloodstream than conventional irinotecan. So we have a prolonged circulation time. It is facilitated by the enhanced permeability and retention effect. That's why we have preferentially accumulation in tumor tissue rather than the normal tissue. It's 5 times lower dose. So we have greater tumor exposure to SN38, which is the active ingredient inside or intratumor exposure. So there is prolonged tumor exposure, and that's we have 3 times stronger and sustained tumor growth inhibition. So we have significant tumor growth inhibition. This is the unique mechanism of action of a liposomal coated irinotecan versus the conventional irinotecan. That's why we are expecting the efficacy and less side effect. Despite this, we had now a head-to-head trial, which is the Napoli-1, which was a phase 3 consistent efficacy trial across primary and secondary endpoint, where we have the liposomal irinotecan plus the 5-FU leucovorin, the Onivide plus the Degramont compared to the Degramont and compared to the liposomal irinotecan as 3-arm comparison. Those for the patient with metastatic pancreatic cancer that progressed on previous gemcitabine-based treatment. Why? Because gemcitabine is the standard of care. As we all know, at this time, second line, if the patient receives gemcitabine, so normally the second line is FOLFOX or even Degramont. Why is it compared with Degramont? Because we had 2 controversial trials. Some trials showed that FOLFOX was superior to 5-FU leucovorin, but also we had a trial showing that FOLFOX is not superior to Degramont. In the contrary, it is inferior, and we had a survival benefit of Degramont over FOLFOX. Perhaps in the second line population, the patients are a little bit frail, and the performance status after the first line are decreased, and the majority of them are a performance 2 patients. This is the patient characteristics of our study population as a second line with the Onivide 5-fluoroleucovorin compared to 5-fluoroleucovorin alone. We see that we had with Onivide 5-FU leucovorin significant median overall survival. We have 6 months compared to 4.2 months. And please remember those 2 months at the second line overall survival are valid because the gem Abrixane took place versus gem at the first line based only on 2 months survival, and even the FOLFIRINOX compared to gem had for us 3+ or less than 4 months median overall survival benefit. So it's the first time we see as a second line an overall survival of 6 months compared to 4.2 with a hazard ratio of 0.67, and 26% of the patients lived longer than 1 year as a second line. Normally, as we said, the majority of patients will not continue our first line or first year if the patient are primary metastatic. Also, the patient who received more than 80% of the targeted dose had a similar survival benefit or even higher, 8.9 compared to 5.1, and here the hazard ratio is much better, 0.57. And also, Onivyde 5-FU leucovorin doubles the median PFS compared to 5-FU leucovorin alone, and with a better response rate, we see an objective response rate of 16 compared to 0.98, almost no response rate in the Gramont regimen, and while maintaining a good quality of life. Regarding toxicity or the profile of toxicity, it was a little bit similar, with the exceptions that we had much more diarrhea and we had much more neutropenia and fatigue. And now the international guideline consistently recommends Onivyde 5-FU leucovorin as a second line regarding NCCN, ESMO, and ASCO recommendation. And here our NCCN, the only category 1 for the second line after GEM, as we see here, is 5-FU leucovorin with liposomal irinotecan, which is a category 1 for metastatic disease. Here also we see the ESMO recommendation if the patient received the first line FOLFIRINOX. But please remember, the patient who received FOLFIRINOX should be a good performance status from 0 to 1, not more than this. The second line is gemcitabine. And for all the patients who received the first line, either gem single agent, who are the patient with PS2, or the frail patient, or even the patient who received gem nab-paclitaxel upon progression, the standard of care regarding also ESMO guidelines is Naleri plus 5-FU leucovorin. So Onivyde also show for us it's on Earth or on clinical background. It's not only the trial, as we see. Perhaps we think that the patients are super selected, that's why we see this survival benefit. But after the introduction of the drug, we see an Austrian trial and the Italian study showing the similar 7 months median overall survival. And we see 2 trials from Asia, from Korea and Japanese, as we see those specific population are doing better with the GIT malignancy. We see a median overall survival exceeding 9 months as a second line. In clinical practice is how we give our treatment. It is an every 2 weeks regimen, while giving the 5-FU leucovorin a continuous infusion regimen with the Onivyde is 70 milligram per meter square over 90 minutes. Please note, we don't need line filter to give our Onivyde. And please note that Onivyde is not equivalent, it's not interchangeable with non-liposomal irinotecan. It should not be interchanged. What's the impact of dose modification? Even if we have dose modification with the Napoli, either dose modification of dose delay, it does not affect the efficacy of our drug, as we see here. Those are the patients who underwent dose reduction. Still, we have a better overall survival, and even we had an overall survival of 9.3, which is higher than the patient who did not have a dose reduction, compared to 5.4 months with an hazard ratio of 0.66, and also the patient with a dose delay, still we see a better benefit with the combination Naleri plus 5-FU leucovorin. So starting with the full dose, then doing delay or dose reduction will not impact either the overall survival or the progression-free survival. Regarding the toxicity and dose modification, the most common toxicity when we are going to use this drug in our clinic is neutropenia, is fatigue, is diarrhea. And we have the dose reduction. How we do the dose reduction? If the patient had toxicity, grade 3, either neutropenia or either diarrhea or other toxicity, we manage the toxicity and then we do 1 dose reduction. So the 70 milligram per meter square is been changed to 50 milligram per meter square. If the patient returned to grade 1 toxicity and neutropenia is over 150 and the motions diarrhea return back to normal, or we are in a grade 1 diarrhea, so we will continue our treatment. And if the grade 3 happened once again, so we do a second dose reduction with a 43 milligram per meter square dose reduction. So we can do 2 dose reduction with the 25% dose reduction of the 5-FU leucovorin, and still we have the overall survival and the progression-free survival benefit. Regarding diarrhea, because we all know that irinotecan has diarrhea, it's a class effect, but being liposomal coated and being preferentially undertaken in the tumor rather than the normal tissue and less drug dose, so we have at least diarrhea than the irinotecan, but it's not head-to-head comparison. How to manage diarrhea? We have early onset diarrhea. Please note that the early onset diarrhea, it's related to the cholinergic effect. The patient can take prophylactic atropine as a prophylaxis, but please note if it's not contraindication. And this if happen in the 24 hours. After 24 hours, we can add, if we had diarrhea, we can add loperamide. But please note, we used loperamide till the patient is 12 hours of diarrhea, and we have to stop it because of the fear of ileus. And if the diarrhea persistent 24 hours after the use of loperamide, so we add antibiotic on top of loperamide. And please note that we don't use loperamide more than 48 hours with diarrhea because of the fear of ileus. Neutropenia management is similar, or febrile neutropenia, that with any other protocol, and we can do 2-dose reduction if needed. So our summary for today: the pancreatic cancer is not a conventional disease to treat. A phase 3 clinical trial demonstrated that Onivyde 5-FU leucovorin clinical benefit. Onivyde is a pegylated liposomal specifically designed to effectively treat this aggressive disease and lead to stronger tumor growth inhibition versus non-liposomal irinotecan. Onivyde 5-FU leucovorin provides meaningful efficacy confirmed in the real world data and confirmed on Earth. Onivyde 5-FU leucovorin is recommended by all main international guidelines. Thank you so much.
Thank you, Professor Rami, for this elegant presentation. And now we have time for 2 questions only because we are behind the schedule.
Thank you, Professor Rami. As usual, very interesting presentation. A new hope in desmal disease like cancer pancreas. My question related to the lesson from CAM2. We can deal with diarrhea. Is the diarrhea of liposomal subtype differ from diarrhea of CAM2?
It's different regarding the mechanism of action. As we know, the pegylated molecule, when it is covered with this glycol, the permeability is better, the time in the circulation is higher, and also the active ingredient is much higher, and almost it has an affinity, higher affinity regarding tumor cells, and the concentration is 1,000 times better efficacy than the non-liposomal coated. But please note that the problem regarding irinotecan and the problem this class effect, that we have to deal it with care for the patient with elevated liver enzymes and the patient with bilirubin, because it's not preferable to give either irinotecan or the liposomal coated for the patient having higher bilirubin than 2. And also, it's contraindicated to give it in the patient with Gilbert syndrome because can have a deficiency in the enzymatic pathway that's responsible for SN38 conversion. So if you're going to use it in this situation, we can use it with caution with dose reduction. This is applied for the CAM2 and this is applied for the Onivyde.
Okay,
but
GemCarb is a standard of care, except in young, fit cancer pancreas, we can start FOLFOX. In this situation, introduction of this molecule lead to reduction or expected reduction in the gain of success as a second line, as we introduced CAM2 in first line.
Yes.
Your opinion or evidence?
It's a very good question because we have a new data, a new valid data. When we are saying that we are using, if we use CAM2 at the first line, it's not recommended to use Onivyde as a second line. But please note that the FOLFIRINOX had a survival benefit when compared to GEM single agent. Now this is the Napoli 1. We had the approval 1 month ago or 1.5 months ago of the Napoli 3. The Napoli 3 was Nalerinox. It was the pegylated liposomal coated irinotecan with the FOLFOX. And what's good in this trial, it was head-to-head compared to nab-paclitaxel. And there was a survival benefit more than 2 months with a good hazard ratio regarding NALIRI-NOx compared to nab-paclitaxel. So we have as a first line, still we did not have the approval in Egypt, but the guidelines now are shifting at the first line. When you will see the NALIRI-FOX at the first line, which is the Onivide with oxaliplatin and irinotecan.
Thank you, Professor Rami. I want to ask whether is there any correlation between toxicity like diarrhea and response or no?
We all know, as an oncologist, a very good question, Professor Hisham, because we all know whenever we have toxicity, we have a response, right? It's not directly like the rash of the anti-EGFR, but in the analysis of the trial or the post-hoc analysis in this trial, we had that the patient who has a dose delay or the patient who had dose delay or dose reduction even had a better survival benefit compared to the other arm. And in this trial, we had a 6 months compared to 4 months in overall survival. The patient with dose reduction had a 9 months median survival compared to 5 months compared to the degramont. So the patient who had toxicity, we are not afraid of the toxicity, we'll do a dose reduction. We do 1 dose reduction, can do 2 dose reduction, and we'll see a response. Because we see in our clinical practice, we do several dose reduction for our patient, we do adjusted dose, we do dose reduction regarding several toxicities, and still we see response. And here it is documented, whenever we had a dose reduction, dose delay, still we have a survival benefit.
Thank you, Professor Rami. And before I close the session, I have a comment only that we have 2 months benefit as regards progression-free survival and more as regards overall survival. And this is very good achievement for such aggressive disease. Thank you.
Thank you so much.
And now I'm honored to introduce my professor, Dr. Lubna Azz Al-Arab, with a case presentation of metastatic CRC. Dr. Lubna.
Which forward?
Okay.
I'm so sorry يا جماعة معلش استحملوني عشان الصوت. But I have a very interesting case of metastatic cancer colon. I will present to share the experience. Oh, please feel free for any comment, any interruption. My case presented 5 years ago. MRA, 36 years old, single female. Presented on February 2018 with abdominal colic, not responding to symptomatic treatment. Sought medical advice, but no response, where CT was requested at that time and referred right colonic mass. But CT requested and referred right colonic mass together with left ovarian high uptake. So we have colonoscopy at that time, which revealed malignant adenocarcinoma. Right hemicolectomy was done due to severe agonizing pain, abdominal pain, not responding to any symptomatic treatment. So the surgery was at that time considered as an emergency with and revealed colonic adenocarcinoma grade 2, free surgical margin and positive lymph node 4 out of 12, infiltrating the muscle layer and serosal fat. Unfortunately, with metastatic adenocarcinoma of colon origin in left ovarian mass. So we have T3 and N2 M1 metastatic cancer colon, or as at that time, Krockenberg tumor at presentation. Now, molecular at that time at 2018 was requested and revealed RAS BRAF gene wild form. At that time, no other molecular biology were requested. As a first line at that time, Folfox plus cetuximab for 6 cycles, and the last was on December 2018. Apart from grade 2 neuropathy and mucositis managed by symptomatic treatment, and the patient proceeded. Thank you, Habib. Thank you. وفي الحقيقة اتعمل لها سيرجري حلو، لأن الكيس دي اتعرضت في قامة التي وكانت لاكي انف ان دخل شيل right hemicolectomy و at the same time tried to preserve the ovulation or the ovarian tissue and surgically resected well the left ovarian mass. She received 6 cycles, developed neuropathy and mucositis, and symptomatically managed. I requested PET at that time after finishing 1 month from the last cycle, and the scan was free. I discussed with the case to continue. On cetuximab plus minus chemotherapy as the patient achieved CR and continued for cetuximab till March 2020. Irregular where this patient presented with irregular uterine bleeding. pelvic ultrasound في الحقيقة ما جاتنيش بقى at that time، هي راحت لجينيكولوجيست عشان هي عندها irregular uterine bleeding، ما كانتش تعرف ان ده related للتيومر. symptomatic treatment قعدت من مارش لحد جولاي. في جولاي the gynecologist requested CT scan and refused right adnexial mass. At that time, she referred for another gynecologist. يعني lost كده تقريبا بتاع 6 شهور لحد ما بيكلمني في يوم ان انا عندي irregular uterine bleeding وانا عندي مشاكل في النساء. قلت لها طب please we have to proceed for PET. PET was requested on September 2020 and compared to the previous scan, and unfortunately found metabolic and morphological progression course of right adnexial mass, almost stationally of left the site of origin in the previous presentation. A newly developed small hypermetabolic right internal iliac lymph node, no evidence of metabolic active recurrent colonic with rising CA19-9 as well as CAA. This is the finding of PET scan, and after MTT, the patient proceeded for surgical resection where complex right adnexial cystic lesion is seen measuring cases. This is the finding of PET scan, and this is the picture of operation. The patient underwent total abdominal hysterectomy, consists of uterine cavity with ovarian mass 10/9, totally infiltrated with the tumor. في الحالة اللي زي دي عشان ovarian mass وما فيش كولون بنعمل immunophenotyping where CDX2 and SADB were strong positive confirming of colon origin. At that time, we retested the RAS. احنا في 2018 يا جماعه في الكانسر كولون ما كانش فيه لسه الايرا اوف سايتنس رايت فروم ليفت، انما in 2020 احنا عارفين ان more common a right side to be wild form، وعارفين كمان ان البروجنوزس completely differ from right to left. So I retested again RAS and it revealed a somatic mutation. As you see, this is the result of my case. Immunophenotyping at that time confirmed it of colonic origin, and at that time again I requested her to the whole panel of molecular biology of cancer colon, and revealed her to negative and stable regarding mismatch repair. So as a conclusion, the tumor are negative for HER2 protein overexpression and stable mismatch repair. So we have to start second line. Second line was FOLFIRI plus BEVA according to guideline. The last cycle was on April 2021. Apart from grade 2 to 3 diarrhea and manageable, together with hand and foot syndrome grade 2 with lubricant and symptomatic treatment, it passed. Follow-up was requested 6 months later on October 2021, attack of hematuria, not severe hematuria and stating homeostatic dose, but infrequent hematuria, where cystoscope was requested at that time and referred again and again, metastatic adenocarcinoma of colonic origin. As you see, this is a bladder mass. This is a bladder mass, and this is a lymph node, perivesical lymph node. PET-CT confirmed that there were at that time a local lesion from bladder and pelvic lymph node. This is the pathological assessment of cystoscopic biopsy and referred of colonic origin. Third line, Folfox cetuximab as a first line. Second line, FOLFIRI and Avastin. Third line, at that time MTT. في الحقيقة أنا عرضتها MTT عشان أقدر أعرف هل في أي دور للسيرجري at that time ولا لا. في الحالات اللي زي دي بيطلبوا MRI to assess cancer peritoneal index. لو الكانسر peritoneal index less than 2 or equal to يبقى العينة دي هتستفاد من السيرجري. طب لو كان more يبقى no benefit of surgery. So long surf I discussed with the patient. خلوا بالكم يا جماعة ان دي بنت 39 سنة بقى لها 5 سنين metastatic breast cancer, metastatic breast colon at presentation, still virgin. فالسايكولوجيكال كونديشن بتاعتها يعني I have to discuss with her. فكان القرار ساعتها ما كانش عندي level of evidence عالي، انما كان عندي phase 2 trial at that time supporting Lonsurf plus Avastin. She agreed. اللونسيرف is well tolerated drug. طبعا حضراتكم عارفين ان هو بيتاخد من day 1 ل day 5، يومين ريست وبعدين 5 ايام وبعدين بقيه الشهر راحه، فده كان مور convenient لها. البيفا بيتاخد مع اللونسيرف in day 1 and day 15 و lucky enough ان هو بيتاخد 5 ملغ بير كي جي، فالدوز بتاعته يعني هي كانت بتاخد just one as a cost benefit. One vial 400 milligram. She started Lonsurf as a third line on 11/2021 with market improvement. ما اديناش radiotherapy على البلادر لان في الحقيقه كنت خايفه من فصله وما عنديش براوند بليدنج عشان ادي homeostatic dose. Improvement after 4 months of therapy and with marvelous reduction in size and activity detected by PET-CT scan. The before and the after. On October 2023, just 1 week ago, this is the last PET scan. The patient دي على Lonsurf Avastin بقالها بالضبط من 11/2021 ل 11/2023 سنتين quality of life بتروح شغلها. الكواليتي اوف لايف بتاعتها يعني هقدر اقول ان في disease control and ما فيش symptoms but at the same time quality of life not deteriorated. As you see, the last PET MRI on October 2023, mild metabolic and morphological regression is still responding in spite of the continuation of treatment. So as a conclusion, this represents the story, the journey of the patient. First line, folfoxituximab. Second line, FOLFIRI-BEVA. Third line, LONSURF-BEVA. What is the evidence? LONSURF plus BEVA. Can we expect more in third line? Yes. Sunlight study addressed this issue beautifully. ESMO 2023 guideline for third line metastatic cancer colon in all biological subtype, RAS wild, RAF white, RAS mutant, BRAF mutant, the highest magnitude of benefit with BEVA plus LONSURF. As you see, the first on left side, the magnitude of benefit with BEVA plus LONSURF is 4, which is the highest combo in RAS wild, RAF white. Again, in RAS mutant, it's also the highest magnitude of benefit compared with regorafenib and LONSURF as a single agent. The last on the right side, exactly with the same, match it with the same RAS, RAF wild and RAS mutant. Again, with NCC guidelines, the last version documented that BEVA plus LONSURF is considered as the preferred regimen. Let us to go rapidly through Sunlight trial. Sunlight trial is a phase 3 international open label randomized trial with nearly 500 metastatic cancer colon on third line were randomized between LONSURF as a single agent or LONSURF plus BEVA. As you see, amazing result. They changed the landscape for third line metastatic cancer colon. It is the first time to see 39 reduction in risk of death in third line metastatic cancer colon with median survival exceeding or nearly 11 months versus 7.5 months. Regarding the progression-free survival, nearly doubled or even more with more than 50% reduction in progression. Our aim in third line management of metastatic cancer colon just to stabilize the disease, just disease control. So just a minute, please. So as you see, disease control exceeding 3/4 of our patient. يعني لو عالجتي 4 حالات في 3 منهم هيكون عندهم disease control, which is great. This is summarize the beauty of the trial. In addition to no gain without pain, what about the toxicity? The only toxicity addressed regarding LONSURF as a single agent compared with combo with BEVA, mild increase with neutropenia and nausea, but not translated to critical situation as no neutropenic death or neutropenic fever was reported in higher degree with LONSURF plus BEVA. I believe hypertension related to BEVA, not related to LONSURF. This is the gain of adding any targeted therapy in first line, second line, third line to the first time to see the magnitude of benefit from 10.8 to 5 compared to 5, nearly doubled. So this Sunlight changed our practice as a third line in metastatic cancer colon. By that, I'd like to thank you.
Dr. Lubna, for this very nice case presentation. وسلامات أولا يعني إن شاء الله معافاة. أنا هبتدي بأول سؤال بس هيبقى سؤال طويل شوية. إحنا ليه استخدمنا التارجت في حين ما إن العيانة كانت completely resected حتى الأوفيريان ماس، سواء أول مرة سواء في الفيرست لاين أو في السكند
في الحقيقة دكتور هشام young age presented with stage دكتور خالد أنا آسفة young age presented with stage 4 كان عندي level of evidence that to continue with targeted therapy especially إنها كانت RAS wild form at the start will push back the progression. So في حالة زي دي في الحقيقة أي حاجة to prolong progression free survival I will proceed.
اوكي. طيب هو تاني سؤال برضو بالنسبة لي وبعد كده اللي هيسأل الفلور مفتوح يعني. considering الهيستوري بتاعت العيانة ودي حاجة individualized بقى، أنا pelvic only recurrences مش recurrence، pelvic only recurrences تمام. هل أنا يجوز لي إن أنا أفكر في consolidative radiotherapy للبلفيك فيلد على اعتباره إن هو ال only site of recurrence مرتين؟ radiation therapy yes.
هو في الحقيقة هي كولون مش ريكتم اوكي والكولون في الراديو ثيرابي اتس نوت بريفابل. واحنا معانا بقى دكتور رامي دكتور ماهر سعادتك يعني وي كان شير ذا اكسبيرينس يعني في الحقيقة الرول اوف راديو ثيرابي ان كولون. تاني حاجة اولا واخيرا it is a metastatic lesion. We treat a systemic disease not a local disease except in very selected cases. امتى افكر في عيانه زي دي في راديوثيرابي؟ مثلا لو كان البلادر infiltration massive، الفاجينا ما كان جالها فاجينا قبل كده massive، otherwise no role except انه هيزود لي توكسيستي وممكن يدخلها في obstruction. العيانه دي اتفتحت 3 مرات فحضرتك رول اوف راديشن في عيانه اوبريتد في بلفس هزود دي في تي هزود الانسيدنس اوف كومبليكيشن. اتس ماي اوبينيون. ولو حد من حضراتكم له راي اي تاني اهلا وسهلا.
في any other question؟
يعني هو انا اتفق مع دكتوره لبنى ان كان هيبقى في رول للبالياتيف راديشن لو في بليدنج سواء هيماتوريا او فاجينال بليدنج كباليشن.
واضيف يا دكتور هشام لو profound bleeding مش bleeding لان هي عندها bleeding بس just drop اوكي مش الحاجه اللي تخليني اتدخل بلوكال راديوثيرابي.
Any other question? Thank you, Dr. Lubna, and I would like Servier for organizing this symposium. Thank you for all.